Hello everyone and welcome to our Acute Physiotherapy podcast. My name is Rachel Moses and I'm a consultant respiratory physio by background, and I'm in a Chief Allied Health Professional role at the moment. And I am super delighted to be joined here by three amazing physios and certainly experts in their field in normal time. But today we're going to be talking about the physiotherapy response to COVID-19 and the challenges that brings. So we've heard in a different podcast about how we treat patients when they're in the intensive care unit. And now we're going to hear a little bit about what happens with patients when they come into hospital, when they're unwell, and how physiotherapists might be involved in the role. So a bit like the other podcasts, this is just people's experiences. This is just what they've been doing in their hospitals. We're not saying this is gold standard. We're not saying this is the only way you can treat people, but this is just an opportunity to learn from people and to hear what's been going on. And I'm massively grateful to these three people because they are open up to criticism and critique. So yes, thanks very much. So I'm just going to introduce everyone. We've got Emma Swingwood on the bottom right of the screen there, who is Respiratory Pathway Lead at the University Hospitals of Bristol and Western. And she is also the Physiotherapy Lead at Nightingale, Bristol. She's got some insight there as well, and also chair of the ACPRC. We then have Claire. Give her a wave, Claire. So Claire is NIV Specialist Practitioner Physiotherapist. So Claire is really well skilled in all things non-invasive ventilation and acute physiotherapy. And then we've got Cath. Give her a wave, Cath, in the top left hand of the screen. And Cath is Respiratory Physiotherapy Lead at Lancashire Teaching Hospitals. So I am going to kick off the first question with an ask about how each of you guys are treating your patients and the pathways that exist between someone coming in through the front door or, they've phoned the NHS helpline and they've got symptoms of COVID and they've got problems breathing or they're brought in via ambulance. What pathways do you guys have for these patients that come in, and what kind of treatments are we using? And if we start off with you there, Emma, that would be great. Oh, Emma, you just need to unmute.
I'm unmuted. So in a way, we've currently got two front doors. So our standard ED still exists and it's still very much open. But then in essence, we've got a COVID ED, which is normally our acute medical assessment unit. And the reason for trying to keep them separate is that if we've got any positive COVIDs or query COVIDs, they're having minimal contact with the rest of the hospital. So they'll either go from the COVID ED, if you like, the decision will be made whether they're for intensive care immediately or whether they can be based on a ward, whether that be a respiratory ward or our more kind of COVID high care area. Once they're on the kind of more COVID wards, we're very much using oxygen therapy. We're very much using CPAP rather than NIV. We have used a little bit of NIV, but actually those are on patients who already have NIV set up at home. So actually it's slightly different. But then from a physio perspective, we're still being physios. We're still using our normal active cycle of breathing, manual techniques, so on and so forth. So still very much a normal physio day, but almost different pathways within the hospital currently exist.
Okay, thanks, Emma. And moving on to you, Claire.
So yeah, we've got a two-site take. So patients will, the ED is based at LRI. So patients coming in via ambulance are acutely unwell that need access to a resus, possibly immediate intubation, will go via the ED pathway, and again in a separate COVID area. Patients who are more stable, who can transfer across to Glenfield, perhaps whose oxygen requirements aren't quite so high, so stable for transfer, come here, and then we have sort of a watch and wait strategy on the wards in COVID areas. So part of the team that I've set up, it's a multidisciplinary team, so comprising of ACPs, physiotherapists, respiratory physiologists and specialist nurses. We watch patients on Nerve Centre, which is our EOBS, looking for any escalations in oxygen therapy. That triggers an early review, and will then offer early interventions such as self-proning, and trying to assess whether the patient is for full active treatment or whether they're for ward-based care, and then stratifying sort of where that patient's managed going forward, depending on whether they need an AGP procedure or not.
Brilliant, thank you. And Cath?
So we're similar to Emma in a way, in that we have a green and red, or COVID and non-COVID areas in our ED, and the patients are assessed there. We are using the clinical frailty scale to help assess the patient, and that helps to determine what sort of pathway they're going to go on. So we have patients might go to ITU if that's appropriate for them, or they might come to our level 2 ward-based beds on the respiratory unit, which does some of those beds are green beds, that's for non-COVID, but most of them are COVID beds at the moment. So it just depends on how we're cohorting the patients. And then similar to Emma again, in terms of our physiotherapy interventions, it has changed how we're working, but a lot of our core basic physiotherapy techniques we're still using an awful lot of.
Fabulous, thanks. And now I just want to pick up on a couple of things there. So Claire, you touched on an Mdt approach that you've developed to help manage your patient numbers. I love that, as you know, love the multi-professional learning. So can you just tell me a little bit about how you've managed to skill people in different ways? If we don't like the word upskilling, because it's just a different skill set, isn't it? And it's about utilising people's skills that they have. So you mentioned physiologists there, as we know, I know you guys have a great team of respiratory physiologists there. How have you done it? What have you done? What recommendations do you have for people?
So I feel really fortunate actually, because normally my day job is to run the acute NIV service, and we do that as a multi-speciality team. But really I was offered a redeployment of a number of staff. So as I said, those comprised of respiratory physiologists who are obviously highly skilled from a home ventilation point of view, but do support our existing acute and IV service as well. So they've been fantastic in supporting some of the traditional patients that are coming in type 2 respiratory failure, in terms of managing their circuits, putting them on safe circuits, doing blood gases for us, setting up NIV, weaning from NIV. So their role has been really important from a technical ventilation point of view. We've also had specialist nurses. So some of the nurses have had, so we've had CPD nurses and pneumonia nurses join us. Fortunately for us, with the COPD nurses we've had have had IT backgrounds, and the pneumonia nurses have had respiratory high care experience as well. So we've been really fortunate actually in the staff that have been redeployed. Alongside those, we've had a couple of AMPs who've joined us, and again they bring a different skill set to the table, and we've actually been able to, the really important thing I think is we've all learned a huge amount from each other, working so closely together, in really challenging circumstances. And the whole team, despite not having worked together before, have really pulled together. They've shared a lot of skills. We tend to go around in pairs, so we'll pair up somebody with a nursing background with a physiologist, or someone with a physiotherapy background with a nurse, and actually that just provides a great combined skill set, particularly when you're thinking about sort of not going in and out of patient rooms all the time. So if the two of us go in between us, we can cover most of the skills. If the patients need drugs giving, if they need an IV setting up, if they need EOBs doing, between us we can cover a lot of interventions to stop sort of multi-professions keep going in and out of rooms all the time. So it's been a great learning experience.
I absolutely love that, and I think that's something we need to bottle and capture moving forward. Now, has anyone else got any other experiences like that, or have been using a workforce with skill sets that we haven't used before alongside physiotherapy? Yep, Cath.
So we haven't, not quite the same as Claire, we haven't necessarily redeployed staff from different professionals back into physio or to support the physiotherapy service. And we've used our skill sets. What we did was like a big skills review of the physiotherapist workforce to identify who did have potentially respiratory physio skills or other skills. So we could use that sort of scoping exercise to decide where patients or where staff might be best placed to support our services moving forward. So we did have some sort of MSK orientated staff that have joined us, and they sort of, it's similar in a way, we've sort of had a buddy system where they might have buddied up with someone who was more experienced from a respiratory point of view to support the work that we're doing. So not necessarily interprofessional, but we've definitely had support networks within the services that we've provided, so that's been really, really beneficial.
I think that's a really good point, and we're going to talk a little bit about how we can prepare a workforce again in the future if we ever need one. But in terms of the ask is, what skills have you got? And I remember doing a podcast about MSK physios, which must be at least 6 or 7 weeks ago now, and those people that have been out of acute care for a long, long time, it's impossible in this scenario to train people up, but actually there's people who have existing skills that are just tucked away a little bit, that with a little bit of refresher training, with a little bit of kind of nurturing and interest. And I think that's the big thing, that the physios and the other allied health professionals that have stepped forward and said, you know, I haven't quite got the level of skill that's needed, but I really want to, and I really want to learn. These are the people we need to capture and kind of give dedicated training to, because they're a workforce just there ready to go. Okay, that's really great, thank you. So let's think a little bit about the patient that comes in, and we have optimized them, if you like, and they are for ward-based treatment. So these are patients that are not for the intensive care unit. Now, we've talked a little bit about some of the modalities that exist, but Claire, if I can come to you first about how you've been managing these patients that have been presenting with COVID who are really unwell. What kind of treatments have you been using?
So in terms of respiratory treatment, we've obviously been using all the basic oxygen therapies. We did have some issues around oxygen conservation earlier on, because our oxygen usage was very high, and we did have a low pressure warning. So we had to adjust all the different types. So we used to use Venturi's, and that's drilled into people, but we actually stopped using Hudson masks because we could entrain less oxygen and achieve the same sort of percentage. So we supported the ward with a lot of that. Going on to sort of higher level AGP respiratory support, we've treated these patients with CPAP. We haven't used high flow. We haven't used nasal high flow. We've used early CPAP with a range of different devices. So originally we started with Max-Tex or high flow driver devices, which plug directly into the oxygen supply. But as I said, we did have some problems with oxygen resources. So our maximum flow rate, which I'm sure is very similar to you, is 3,000 litres a minute for this site. And we did get to the sort of 2,600 mark. As a result of that, we then made a rapid decision to use the high flow drivers much less, and to switch over to NIPI devices that are traditionally used for non-invasive ventilation, but in the CPAP mode, in training low flow oxygen into the circuits, more than we've used normally for hypercapnic respiratory failure. So we're sort of talking 10 to 15 plus litres. So we have occasionally needed to put 2 oxygen ports in the circuits with a dual flow meter where we've needed to. So no experience with high flow or nasal high flow, simply because we couldn't create a safe circuit. We don't commonly use nasal high flow on this site anyway, although we have got 5 new airways raring to go. But we haven't introduced that because it's a new skill for the staff to learn in an already stressful environment with enough training and things for them to do. So yeah, predominantly CPAP.
And just you mentioned about circuitry, and obviously NIV and services differ across country, but in terms of filters has been a big problem for people, and it become a critical stock item at one point. So are you, I presume, using viral filters, and do you use a viral filter at the patient end before the exhalation port with non-vented masks? Is that the kind of setup you're using?
Yeah, so exactly. So normally for a non-invasive ventilation service, we run, as I'm sure many of you do, a vented face mask and a non-vented circuit. So another reason why we had to put a team of specialists together is we had to overnight convert our whole NIV or CPAP circuits to safe circuits. So as you describe, non-vented face mask with a bacterial viral filter followed by an oxygen concentrator and an expiratory port in the circuit. So a completely different system for us. A lot of teaching and training around that, and lots of leaflets, flyers, laminated cards stuck everywhere, just so people could quickly pick up on the difference with the circuits. And then the filters changed every day. We haven't been changing the actual circuit unless there was a problem with the circuit, just because of the critical shortages of stock. But the circuits are staying visibly clean, because obviously there's a filter at the patient end, so doesn't seem to be a problem there.
Fabulous, thanks. And Emma, if I could come to you, just about your experiences.
Ours is really similar to Claire, to be honest. Oxygen therapy for sure. We've been able to stick with Venturi systems. Again, our pathway fits with the best flow of oxygen availability through the hospital. So that has been planned with that in mind. So that hasn't been a problem for us. What we have noticed is that almost the thresholds for the next step of treatment, so from oxygen therapy up to CPAP, is much lower than normal. So really, as soon as somebody's hitting 35-40% oxygen, we have been thinking about CPAP, and quite often they're going on it at that point. And I do think that has helped our outcomes for sure. And then again, same with Claire, much higher levels of CPAP than we would traditionally use. So we are kind of 10-15 plus for sure. And again, needing the device on for a much longer duration of time. So kind of, 10-14 days has been quite normal, sometimes even longer. And when they're on it, they're not changing very much. So I think patience has been the key. And then same as Claire mentioned, we've obviously changed to non-vented masks, which has worked absolutely fine. But again, that came with a massive amount of teaching, and I think our physio team here, especially from medicine, and our CF team played a huge role in that teaching, initially for the therapy staff, but then that escalated to the nursing staff and medics as well. Lots of communication tools, lots of laminated sheets, do's, don'ts, comms on the ward as well, and it seems, touchwood, has worked really, really well, but definitely a team effort for sure.
Okay, and it's really interesting, isn't it? Because again, we are so grateful to our colleagues in Italy and in China who really shared their experiences, and we had a head start, for choice of better words, in that we knew that CPAP would be used with these patients. We knew that non-invasive ventilation wasn't going to be effective, obviously, because this was predominantly a hypoxemic condition, an ARDS type picture. Now, nationally, we've seen huge variance in success with CPAP, and we're not sure how that's kind of going to be collected or reported, but certainly just speaking across the networks, we've seen that. And as you said, Emma, thresholds for starting CPAP when patients are on oxygen, because a lot of people have managed to be turned around with 15 litres of oxygen, as long as the CO2 is not climbing, as long as the fatigue's not significant. And it's about being patient. It's about giving the lungs time to rest and recover, and kind of if just waiting and being patient. So that kind of brings on a little bit to optimization for these patients. So we've talked about oxygen therapy, CPAP, optimizing physiologically as best we can, pharmacologically and with devices. But there is been a very specific role for physiotherapy in this part of the treatment pathway. So Cath, do you want to tell us a little bit about your experiences of what physios have been doing to help optimize?
Yeah, certainly. So we've done a lot of work really around proning the awake patient. We did start developing that service quite early on at Preston Hospital, and initially we were proning our awake CPAP patients with some limited success, but then as we got a little bit better at identifying who should be proned and getting that criteria in place and implementing it, we started to prone a little bit earlier. So before, we talking about thresholds, so sort of as the kind of before that, reaching that significant threshold where they needed to go on CPAP, and we've seen some slightly better results by implementing it a lot earlier. So that's been really good.
So in terms of So one of my colleagues explained awake proning to me nicely when they said if the patient can get themselves in prone, just let them try it. So you'd have a different strategy, do you? Will you actively look at a certain oxygen level, look at the patient's respiratory rate, look at their work of breathing, and then ask them to stay prone for, say, so many hours? Or
yeah, so how we're working at the moment is the patient has to be able to get themselves into prone and out of prone, but if they need a little bit of assistance or a little bit of moving and handling techniques to help them manage that, then we'll be offering that. It is quite a physio-led service where we're delivering it. The nurses are supporting us, and it's been a great Mdt approach, but certainly it's definitely physio-led. So we're trying to identify anybody that has slightly higher oxygen requirements, so sort of an FiO2 above 28%, and obviously no contraindications, but the patient can cooperate and communicate with you. So we're using a ward round in the morning. So we use an MDT ward round to kind of identify who those patients are, and then the physios will go and start implementing the proning. We aim for 2 hours, and we're aiming to do that 4 times a day. So we're utilising our twilight physio shifts and our nighttime shifts to help get those 4 episodes in for each patient as much as possible. And so far it's been working really well. The MDT team and the medical consultants are finding it really beneficial with some good outcomes.
And you mentioned some other types of physio modalities in that, so active cycle of breathing, relaxed breathing, positioning, patients that have secretion problems maybe being alternate sideline into a really good lateral position, not just kind of with a little pillow behind the back. Do you want to talk to us a little bit about how physio skills are being utilised in that manner? And some people might call them old school, but actually they're physiologically, there's a lot of sense, isn't there?
Yeah, there's a lot of sound reasoning for why we're using those sort of old school techniques, or our bread and butter techniques. So we are using ACPRC, and what we're trying to concentrate is on the diaphragmatic breathing part of that cycle, because we are finding with some patients with the increased respiratory rate that is tending to lead to a sort of altered breathing type pattern. So we're really using ACPRC, but really tend to focus longer on episodes of diaphragmatic breathing and breathing control part of the cycle. So we're using that. We're using some manual techniques as and where appropriate. We're not really auscultating any chests. We're kind of going off what we can hear and what hear audibly, and what we can feel with our hands and palpation. And then positioning is huge. Definitely sideline. If patients can't tolerate prone, then definitely get them to a really good sideline position. And lots of education as well about why we're doing these techniques with patients. Some people are a bit sceptical about prone in particular, but certainly we've been able to explain it from a physiotherapy perspective. We are getting a lot better cooperation.
Yeah, and you mentioned about twilight and 24-hour shifts. Like, we know up and down the country that physios have really stepped up. We've provided 24-hour, 7 days a week physio for a long time. But to actually do 24-hour full shifts, night shifts, alongside our nurses and our medics has been and radiographers has been a massive change of practice, if you like. And we're hearing the real value of everything you've just described with prone and with assessment, with physio intervention being there 24 hours a day. And certainly I know a nurse said to me the other day she doesn't know how she's going to go back to not having a physio, at 4 o'clock in the morning, just to say, oh, can you come and give us a hand with this? So we need to be mindful of that. Emma, can I just bring you in? You manage a big team of acute respiratory physios and on-call physios. Can I just bring you in for any comments on that or shared experiences?
For the proning?
For any of the kind of physio 24 hours a day, kind of what your experiences are and what have been the added values for optimising this patient group?
So we've been really lucky, actually. We haven't had to go to 2 lots of 12-hour shifts or anything. We've managed with a fully staffed day shift, if you like, and then there's 2 people on call, and then they're coming in for the evening safety brief with the wards. That has been an absolute key, especially for the weaning of the CPAP, but also for the awake proning side of things. So again, our teams, like Cath touched on the communication of this, but the teams have created proning leaflets for the patient. So they have got pictures to be looking at and some explanation of why we're asking them to lie on their tummy. They've got weaning charts that are up at the entrance to bays, to doors, to obviously help communicate with the nursing staff when we're not there, and that has all made such a difference, and the nurses have been fully on board. So it is a physio-led process, same with Cath, but there's no way that we could have probably got the outcomes that we have had with awake proning unless the nurses were fully on board, without a shadow of a doubt. So I think for me, the main learnings of how to optimise the patient has purely been from an MDT approach. Yes, without a shadow of a doubt, the physios have stepped up, and we've really been able to show what we're absolutely made of. All of our anatomy, physiology knowledge, it's brilliant. But the fact that we also can be brought into a team at very short notice and make it work, and work with different teams of people who also aren't used to those environments. Again, I think we've come into our own, and hopefully have got really good outcomes for our patients.
Brilliant, agreed. Claire, definitely going to bring you in here with your multi-professional hat on as well.
So I just wanted to pick up on a couple of points in terms of, I mean, I don't work directly for physio, but they've been really quite radical in what they've done. Again, they haven't done night shifts, but they basically redeployed a huge proportion of their neuro, orthopedic, and I'm sure there are others that I've not highlighted, but to enable both sites, or all three sites actually, to run a 7-day enhanced service. So Saturdays and Sundays, we've had 13 physiotherapists on our site, which has just been amazing. So alongside my team that have been providing enhanced respiratory care, of course, they've been providing a huge amount of resource as well, with their expertise, as you're describing, in NIV and CPAP, and picking up on the self-proning as well. So that's kind of added a huge army of people, if you like. Just going back to the CPAP patients and optimising their care, and I just was interested to hear how other people have managed this. Obviously, these CPAP patients, as Emma mentioned, have been on CPAP for a prolonged period of time. And my experience is they don't do well at all with having short breaks off CPAP. And I just wondered how you'd manage that from a hydration and from a fluid balance and a feeding point of view.
Emma, we'll come to you first.
I think we quickly realised exactly the same problem, because as soon as they come off CPAP, they're going on to 15-litre non-rebreathe, which is obviously the most unpleasant thing ever, and we're then still struggling to eat, drink because of breathlessness and fatigue. So we very quickly got our dietetic colleagues on board and on the ward, and they've been an amazing resource. So some of our patients have had early NGs to help with their nutrition and their hydration, because again, their calorie utilization is so high, and these COVID patients are behaving quite differently from an energy requirement perspective, maybe to what we've seen before. Especially, again, a lot of the comparisons have been to hypercapnic COPDs, but actually they couldn't be further apart. So I think very quickly we learnt that, and dietetics have been brilliant. So we've been very lucky.
Fabulous. And Cath, obviously we used to work together. I know we have a fabulous nutritional team and dietetic team. What's your experiences?
Very similar again, really, and it has been quite a huge concern for the whole MDT regarding the difficulty these patients are having maintaining their hydration and nutrition. You just see that they just can't manage it, and it's quite heartbreaking in some instances, really. So say it's similar, really, an MDT approach. Dietetics have proved to be absolute stars in helping to promote that and manage it, and we've also done a lot of work around oral health as well, and trying to mouth matters and things like that to try and just compensate for some of those difficulties. So very similar experiences, I would say.
Absolutely. This is where the speeches come in, isn't it, in a world of their own, in terms of high flow oxygen, however you give it for a long period of time, is awful on the mouth, and with reduced appetite, with taste and smell disturbances that come with COVID. This is where we're all advocating on a massive multidisciplinary team approach, and not forgetting my OTs and my psychologists and everyone else that comes in. So this is going to move into a slightly more sensitive area around advanced care planning and those patients that sadly don't get better and won't recover from COVID-19, and that will die. And when we were first planning for this pandemic, we realised very quickly, particularly in my home trust at the time, which was with Cath at Lancashire Teaching Hospitals, that we have a fantastic palliative care team, and they work 7 days a week and they work extended hours. But actually, with the numbers we might have been facing, we needed to prepare our physiotherapy workforce that they may well be caring for patients at the end of life. And for a lot of physiotherapists, they might have never seen a patient die, for example, or been there when the patient dies. So I wanted to just ask you guys, in terms of starting with you, Claire, in particular, about how you have, prepared your workforce for that, how you have managed advanced care planning in your hospital and changes that might have been made, and what advice you have for other physio or AHP managers out there and how they can prepare in the future.
So I guess everybody's experience is going to be a bit different in this scenario. Personally, my team have been more closely involved for people who are on CPAP, whose ceiling of treatment is for ward-based care. Now, everybody's outcomes have been different in this area, but I think the common theme is a lot of these patients are unfortunately dying, and as a multidisciplinary team, we're doing our absolute best to make sure that these patients are comfortable. We're in regular contact with their relatives. Where possible, we've been getting the relatives in for last hours of life. Or I know our palliative care teams have been doing video links with some of the families as the families have wanted to and as they felt that's appropriate. We have been really lucky in that we've had enhanced support from our palliative care team, who've been available 7 days a week in the hospital and on call out of hours. They've supported a lot of these patients, and actually our early experiences with some of these patients were getting very breathless. So despite being on CPAP, they were still looking very scared and quite breathless. And we were actually managing that quite successfully, running syringe drivers alongside CPAP, but with very low levels of sedation in, just to make sure that patients were comfortable. And being managed very carefully. So on our nursing staff on the wards, we've been, our COVID AGP area has been predominantly staffed by our NIV team, who are really well skilled in this area, and actually their expertise of providing care in the final hours of life has been invaluable as well.
Yeah, I have to say, from my experience and from what I'm hearing nationally, is there's been a huge focus on dying matters and about advanced care planning, and I think as a healthcare system, that's something that we are all should be extremely proud of, to make sure that part of the patient's journey in life is as optimal and as kind and as caring as it can be. And I know every single acute physio or AHP that I've spoken to says exactly the same, and it's so reassuring, isn't it? Because we've all friends or colleagues or know someone who's been affected by this. So that's great. Thank you, Claire. Okay, so moving on to the patients that do get better. But sometimes we'll always leave the advanced care planning bit till the end, so I really didn't want to do that. So I'm going to move on to the patients that are optimised and who do get better, and where physio and therapy kind of comes into its own in terms of rehabilitating these patients. So we have been doing this kind of stuff for years, but everyone has an opinion on it now and how we do it. So you guys have been, at the coalface treating these patients. How have we been managing these patients and some of the challenges that we have? We talk about fatigue, malaise, breathlessness, but breathlessness actually not always being the main limiting factor, nutritional depletion and massive separation anxiety, and probably post-traumatic stress with the whole situation of coming in, having the diagnosis, staff and PPE, and not having those normal family interactions. So Emma, if I can start with you, please, about how how physios have been managing that stage of the patient's recovery.
I think one of the main things that we've done probably without realising is shouting and trying to spread the knowledge that rehab isn't just physical. So yes, these patients are quite weak because they haven't been able to do anything. You've got the impact of potentially prolonged bed rest, the impact of potentially an ITU stay, which is all things that we are used to dealing with. We have seen differences between weakness between the upper limbs and the lower limbs, whether this is to do with proning or not, I don't know. So we've dealt with that, but also trying to get across to our MDT colleagues and medics that actually the rehab is physical, but it's also cognitive, because of these microemboli that are being thrown off here, there and everywhere. But also there is a massive, as you touched on, a psychological element to the rehab as well, making sure that we are working with the patients to get them engaged in the process, but also making sure that we're listening to how they're feeling. I think you've got a very different cohort of patients. Again, they are quite a lot younger than how you would see critically ill patients, and so their knowledge of COVID prior to even getting ill or coming in, everything is about COVID in the media, and so you've then got somebody who's heard all of this on the outside and suddenly they're in the middle of it, feeling really quite unwell, and then obviously being treated by people in full PPE, and obviously we don't look normal, we don't even look like ourselves at all. So I think the impact of that is massive. But I think as much as we are working very closely from a physio perspective with our OT colleagues and our psychologists, my concern is actually we don't truly know the impact of COVID and what these patients' rehab needs are at the stage of them being discharged. I think the impacts are probably going to progress, and maybe some patients might get worse, and before we know the true extent of their clinical needs. So I think from what we're actually doing, we're obviously doing loads of rehab from as early as possible from ITU, but obviously ward-based care as well, very much so. So trying to be as functional as possible, because if there is a cognitive need from this group, they need to be as functional as possible, because it's simpler, it makes sense to them, and then they're also achieving things. So even if it is standing by a window to then have a conversation on iPad, anything like that, it just needs to be simple. But as you say, they are fatiguing very, very quickly. So rather than it be a really juicy rehab session that might take 45 minutes to an hour, they're much, much shorter. So some of these patients will need a good couple of rehab sessions a day to have something that then is going to carry over for hopefully long-term benefit. So an MDT approach and communication about the fact that rehab is not just physical, it's way more than just weak arms and legs.
Mm-hmm. Absolutely, and I think you've hit the nail on the head there. I think and to be fair, there's been the media coverage that's been out there has been very physio biased, and we are the first to say as physios we cannot rehabilitate these patients alone. We need a multidisciplinary team, and that will be people that traditionally might have heard of, like OT for function and occupation, but actually cognition is huge, and psychologists and our physiologists, our speech and language therapists, dietitians, we can't promote this enough, can't we not? We need to make that really clear. So Cath, moving on to you in terms of the specific kind of physiotherapy or physiotherapeutic interventions that you've seen in your hospital.
So certainly from an early rehab point of view, it has been, again, some of those traditional techniques, so sort of bed exercises, strengthening exercises on the bed or in the chair, and certainly sometimes just getting the patient to sit on the edge of the bed has felt like a whole rehab session in itself. But again, trying to make that quite functional, so there's a reason to sit on the edge of the bed. It might be to look at the phone, call the loved ones. It might be to have a drink on the edge of the bed because that's much easier. So, and then just progressing that, but the progression has been really quite slow. It is limited by fatigue and by breathlessness and by desaturation as well. They sort of presenting a little bit like fibrosis patients who just, have a really limited exercise tolerance. So very small, limited rehab sessions that you just try and do as often as possible. And that's where our therapy assistants, particularly for us, have been a huge support and in implementing those little sessions. So quite similar experiences again, I'd say, but really beneficial.
Yeah, and sadly we have heard of reports across the country, certainly two two colleagues have experienced this themselves about sudden death. So either sudden desaturations, and people who are on a moderate level of oxygen, sudden desaturations either during some form of activity or just even sat in the bed, and then patients who have sadly passed away very suddenly when we didn't expect, probably due to, as Emma mentioned, the embolic nature of the disease and what that brings. So Cath, I just want to move on to the little, well, it wasn't little, it was a big project you'd done, the COVID recovery advice, patient information thing you pulled together really quickly. Just tell us a little bit about that. I'm sure it'll be on the ACPRC website, linked into this podcast for people to download for free, but just give a little feel about what that is.
So similar to our conversation today, really, we had conversations with senior respiratory colleagues at the Trust, and we sort of identified that there was likely to be a lack of information for patients on discharge. So patients would be well enough to leave the hospital, but that they could have anxiety about some ongoing effects of COVID-19. So we wanted to produce a resource and pull that together with an MDT. So we had speech language therapists, dietitians, occupational therapists, physios, specialist nurses, psychologists, to put this multimedia web resource together. And it's we're really happy for everybody to share it and use it. It's got different elements to it, so videos, exercises, text, interactive pieces, and the whole purpose really was to just provide patients with some initial information for that initial recovery period. So there's still a lot of work to do on rehabilitation and what the long-term effects of COVID-19 will be and what rehabilitation will look like in the future. And this resource was primarily aimed at that initial recovery period, to provide information, to provide some signposting to other information that would be needed and support, and really just offering that reassurance that some of the effects that they're feeling when they are going to be at home is normal to some extent, but if they're worried, how to manage that and how to seek further guidance.
Well, brilliant, it's excellent. And again, for those of you that are listening or watching and you haven't seen it, please go and use it. Don't reinvent the wheel. It's brilliant. So Claire, I'm going to move on to you with regards to discharge. So we have struggled to have a unified discharge pathway for patients who've been critically unwell in ITU, or even with severe respiratory disease who weren't in ICU before. So but now we obviously have a sudden influx of patients who have presented with COVID-19 who actually have very similar, and when they're ill enough to go into hospital, have very similar kind of phenotypes in what we're saying with regards to the neuropathic pain elements, severe muscle weakness, severe fatigue and lethargy, potentially ongoing breathlessness, and the psychological cognitive impact like Emma described on the back of anxieties around getting unwell again. So as best as you can, and maybe using experiences that you've had yourself, can you describe kind of what we need to be doing for these patients on discharge who don't want to stay in hospital, by the way, they don't want to stay in, they want to get home, and what we need to do as a profession?
So I can kind of speak loosely from the experiences that the physiotherapists here have told me about. They've been extremely proactive here, working alongside our pulmonary rehab teams and some of our respiratory consultants and our community colleagues, trying to pull together a comprehensive package of rehab, taking into account, as you've said, that we don't fully understand the rehab needs of these patients yet. And also, as you mentioned earlier, we don't really understand which outcome measures to do with the patient. So I know the colleagues here are doing a battery of outcome measures before the patients leave hospital where possible. There's a different system, so depending on the needs of the patients, they're referring to community rehab, or I believe they developed a new team called the React team, which I can't remember what it stands for, but essentially it's providing sort of enhanced respiratory rehab and follow-up for patients who've got more complex needs, more respiratory kind of rehab needs as well. Alongside that, sort of more broadly speaking, I know some of my respiratory consultant colleagues are working quite rapidly to set up a COVID follow-up clinic. So our pneumonia nurses have been redeployed into screening all the COVID patients and putting them into a follow-up clinic, which I think will run similar to our breathlessness clinic, which is led by Rachel Evans, one of our respiratory consultant colleagues, and that it'll be multidisciplinary, and there'll be lots of sort of testing done along the way, some spirometry testing, and then some physical kind of outcome measures. And I know all those patients, I believe, are going to be offered something similar, but perhaps tailored specifically for COVID in terms of pulmonary rehab. So a combination of community rehab, follow-up from the hospital, and then coming back to this COVID follow-up clinic.
Yeah, so one of the podcasts is in exactly that kind of post-acute rehab and what we need, and that podcast includes some of the work that's been going on by the academics, the really clever people and the researchers, and about people who are already running post-ICU or post-discharge clinics. For the majority of hospitals, they don't have that infrastructure. Obviously, you guys, where you are, have a fantastic infrastructure and clinicians and therapists. And for a lot of people, this will just be the complete unknown. And as much as we're awaiting national guidance on what we should be aiming for, it's very much going to boil down to locality and what's available in the locality, isn't it? So I think the most helpful things that can come out about giving advice to clinicians who are going to be discharging patients is, you know, what to look out for, understand what's available in your local area, and trying to somehow keep a track of patients that are being discharged post-COVID. Now that can be clinicians, consultant level, that can be therapists, but really the question is, within your organisation, do you know who you're discharging? Do you know where they're going to? Do you know what rehab needs they have? And how can they get back in touch with you? Lots of services doing 2-week telephone follow-ups, particularly with staff who may be shielding at home, or who can't work if they're vulnerable, which is a great idea in terms of collecting and understanding what those patients might need. So the patients might tell you what their needs are. And again, if that's going to be clinic-based, based in a hospital, if it's going to be in the community, there's so much variance, there's so much unknown, isn't there? But it's very, very key that therapists, physiotherapists, other therapists are the key in this. And what our big ask is that we're resourced to do this, aren't we? We have a lot of skills, whether you be a community therapist, whether you be a hospital therapist, but we can't do everything. So we're going to need that support and that resource allocation to be able to do it, but we have the skills to do it. So that's kind of bringing together everything that we've talked about in the role of physio in the acute management. So it's at the very beginning, isn't it? It's planning, it's education, it's teaching, it's providing a skill set to people that maybe they didn't have before, or redesigning the skills that they do have to meet the needs of the patients that we're seeing. It's about equipment and procurement. Claire, you talked a lot about safety and about oxygen and about circuitry and masks and machines, and actually troubleshooting when you're using something and it's not quite going right, and what else do you need? There's a huge governance element around that, and we know that with our dietitians, like the governance around enteral feeding and nutritional depletion, and the do's and the don'ts, like you said, with these patients. What do you definitely need to do and what do you definitely need not to do? We talked about the treatment, the specific treatment for COVID patients, the generic treatment that we know has always existed for patients with significant respiratory disease and comorbidities and acute respiratory failure, and how that manifests in terms of rehab needs, and how we are great listeners in terms of being patient and listening to what the patient needs and wants. And then the advanced care planning element, as well as the discharge element. So a huge role in managing the complexities of COVID-19, and hopefully again something we can help showcase for all the right reasons about the added value of having us as part of the multidisciplinary team. So I'm just going to go around and ask anyone if they've got anything else to add. Emma, I'll start with you.
I don't think so necessarily. I think the only thing we haven't touched on is the well-being of our staff, which kind of goes without saying that it is really important. But I think we've made an effort to really give permission to people to take time out during a working day. And I think that will continue for quite a long time.
That's a really excellent point, Emma. And we have, for those of you that haven't seen it, we have a whole podcast on psychology, and that absolutely talks about patient psychology and staff psychology. So that's you're showing your great leadership skills there, Emma. Claire, can I move on to you?
Yeah, I just wanted to pick up on the fact that we've all talked about CPAP being used as a treatment, and quite quickly it's become, it seems to be, a standard of care in terms of perhaps using CPAP before patients go to ITU, certainly in some centres. And I think it's just worth mentioning that that is a standard of care that seems to be developing. We don't actually have the evidence to say at this stage whether that is the correct pathway for the patients or whether early intubation is a better option. So I'm sure many of you guys are aware of the recovery respiratory support trial. So we're certainly participating in that, and I think it's really important that we do participate in that, so we do get some evidence-based answers as actually to what is the correct pathway for those patients.
Brilliant, excellent, Claire. Cath?
I think my final thoughts really are this pandemic has been an absolute unique time in my physiotherapy career, as I'm sure it is for everybody else. And it's really how, although it's been a really sad and really difficult and challenging time, that there have been opportunities that have come from this crisis, and particularly for physiotherapists. And for me, it's just thinking about how we build bridges moving into the future with in the new world of where we're all going to live with COVID and work with COVID. So I think there are huge opportunities there, and it's really has been great to be able to show the value of physiotherapy in this really sad time.
Fabulous, thank you. And I just want to say a massive thank you to you all, and just congratulate you, Cath. Your educational package is incredible. Claire, what you've achieved with your multi-professional work, and on top of everything else you already do, is amazing. And Emma, you know, special thanks to you, especially, you know, your Nightingale work and the ACPRC work, you know, banging all of the information out there in such quick time. We're really grateful, so thank you all. And I'm just going to stop recording.